And then, thank you for starting that. So we do just want to review, as part of our Preconception CoIIN project, what our overall goal was. And that's that this Preconception CoIIN will develop, implement, and disseminate a woman-centered, clinician-engaged, community-involved approach to the Well Woman visit to improve the preconception health status of women of reproductive age, particularly low-income women and women of color. And we're so excited to have Dr. Ann Steiner with us today to talk about racial disparities in infertility. This is one of the webinars that we're doing in a series this month. So again, please go to that website to look and learn more. And with that, I'm going to turn it over to Erin to introduce Dr. Steiner.
Yeah, thanks, Catherine. As Catherine said, we are so delighted to have Ann Steiner here today. She's a professor and chief of the Division of Reproductive Endocrinology and Infertility in the Department of OBGYN at Duke University. And her research focuses on reproductive aging, anti-Mullerian hormone, and predictors of fertility and infertility. She's also the editor-in-chief for FNS Reviews, which is an American Society for Reproductive Medicine journal. And she's been a women's reproductive health research scholar and received a number of awards, including a Junior Faculty Award, the Jefferson Pilot Fellowship Award, and Best Doctors recognition. And we are so lucky to have her here today to talk about racial disparities in infertility. Take it away, Dr. Steiner. Thanks.
Thank you, Erin, for that introduction and everyone for the invitation. Going to move ahead here. Let me see. Okay. So first of all, I want to present, just let you know about my disclosures. One major disclosure is that I am the editor-in-chief of FNS Reviews, and I will say that I selected an article from FNS Reviews for discussion largely, which I'll be just going over today and citing quite a bit. So if you have questions and desire to hear more about this topic, I would recommend that you do see this article in FNS Reviews by Jackson Bay et al. I want to also mention that this talk is going to focus on Black women. I am speaking of Black as a race, as a social construct. And, excuse me, there's a little delay here. Oh, how do I get back here? Let's see here. Oh, a little finicky. Okay. And I should note that I'm not referring to anything, I'm not speaking about ancestry or genetics when I mention or talk about Black women. For most of this talk, I'll be using as a comparison non-Hispanic white women as the control group, as a comparison group. Beginning off, I'd also like to state a disclaimer that I know I am not a Black woman. I've never experienced being a Black woman, and I do not speak in any form or fashion for Black women in my talk today. However, I am a provider of fertility services, meaning I evaluate and treat infertility to Black women, and I hope to be an advocate. The objectives today for this talk is to help everyone better understand the racial disparities in infertility diagnosis and treatment, explore factors that potentially contribute to these disparities, and learn interventions to mitigate inequities. I'd like for you to know that I will not be talking about disparities in assisted reproductive technology or IVF outcomes, although they do exist. And the reason is that I assumed that I was not speaking to a bunch of reproductive and endocrinologists today, and instead would be focusing on things that I believe actually may contribute to later on these disparities in ART outcomes and potentially have a greater impact. As we move forward, the prevalence of infertility is more common in non-Hispanic Black women. Compared to white women, Black women have 1.45 times greater adjusted prevalence of infertility. And this was from the National Survey for Family Growth. And what are the potential contributing factors for this disparity? Well, one may be the prevalence of pelvic inflammatory disease, which is caused by untreated sexually transmitted infections such as gonorrhea and chlamydia. And I like to stress the untreated. We're not talking and stating that there is more prevalence of gonorrhea and chlamydia necessarily, but the importance of the effects of untreated gonorrhea and chlamydia leading to pelvic inflammatory disease. Pelvic inflammatory disease affects 8% of all reproductive age women, but disproportionately affects 11% of African American reproductive age women in the US. Unfortunately, pelvic inflammatory disease significantly increases the risk of infertility, such that the rate of infertility is 18% in women that have a history of PID. What we know is that asymptomatic STI screening and early treatment reduces occurrence of pelvic inflammatory disease, and thus plays an important role in the prevention of PID and subsequent infertility. Another factor that may be contributing to the increased prevalence of infertility amongst Black women is the prevalence of fibroids. And I'm going to be quoting a study today that was done by Donna Baird et al., in which she enrolled 35 women 35 to 49 years of age and followed them for 8 years. And this was done between 1996, where they were enrolled between 1996 and 1999. She enrolled 895 women, with 515 of those being African American. And I'm using the term African American here as this was how they were described in the paper. I think what's important to know is we learned quite a bit about prevalence of fibroids and quite a bit about burden and timing of fibroid occurrence. What we found is that fibroids occur in 50% of white women and 75% of African American women. In addition, African American women had a larger fibroid burden, meaning many more fibroids and larger fibroids. And in general, fibroids are seen approximately 2 to 3 years earlier than in white women, meaning Black women are diagnosed at an earlier age. Why is this important? Well, what are fibroids? I should say these are these benign uterine growths or tumors that are obviously found in the uterus. It is the most common tumor of the reproductive tract, and they can in themselves cause infertility, either due to inflammation or causing problems with implantation or obstruction of the fallopian tubes. But what I'd like to focus on today is the other reason why I think it may be contributing significantly to infertility, the higher incidence of infertility in Black women. And that is the management of fibroids. This is another study by Donna Baird using the same cohort. And what you see here shows you how the major uterine procedures that during the 8 years of follow-up during this fibroid study. On the left side, you have the various procedures that were performed to manage the fibroids. And then you see the two groups, the white and then the African American group. What I'd like to focus here is the percentage, meaning in the hysterectomy group, this only 45% of the white women had a hysterectomy, but 74% of the Black women had a hysterectomy. And a hysterectomy pretty much makes it impossible to have children. Whereas the prevalence of fertility sparing procedures or management of fibroids was much higher amongst white women. 31% of white women received myomectomy, whereas only 5% of African American women. And hysteroscopic resection was 17% of white women and only 8% of African American women. Thus, it's not only the increased prevalence of fibroids that's the issue, but also how we're managing them. What about tubal ligation? Well, what we found is that tubal ligation or permanent sterilization of women is much more likely to occur in Black women. In this one study, the odds ratio was 1.22 in Black compared to white women. And unfortunately, Black women were also more significantly likely to answer, less likely to answer correctly for knowledge items assessing knowledge about the reversibility of tubal sterilization. So in other words, they had a poor understanding that tubal sterilization is not reversible. And then when we look at management of things like ectopic pregnancy or other situations where tubal conserving surgery can be performed, what we found is that Black and Hispanic patients were much less likely to have tubal conserving surgery for such procedures such as ectopic pregnancy compared to white women, such that they were much likely to have their fallopian tubes removed instead of spared. What about access to care? Well, we know among women with infertility, Black women are less likely to see a doctor compared to white women. In addition, when you look at women that do seek care for their infertility, Black women waited twice as long on average before seeking help compared to white women. In addition, Black women are less likely to receive fertility services than other women. The prevalence of using any medical services to help get pregnant was lower for Black women, almost half that, compared to white women. And this was seen in the National Survey for Family Growth. In the Haynes study, they showed that Black women, 40% of Black women sought treatment, and while 80% of white women sought treatment. And heterosexual white women received medical fertility assistance at almost double the rate of women who identified as non-white, sexual minority, or both. Differences were only partially mediated by insurance coverage and income. So the question I wanted to answer then next was, what can I do? Well, first of all, I think importance is, one second. Let me get back to the slide. If we can see this. Excuse me. Let's see here. Okay. There we go. So awareness. First of all, I think it's important to be aware of the social stigma. African-American women are 3 to 4 more times likely to be concerned with having failed to conceive, using science to conceive, the social stigma of infertility, and disappointing their spouse. And also the term trying to get pregnant is potentially culturally insensitive, meaning some women try to conceive or will purposefully stop birth control and then try to get pregnant. And some women perceive it more as stopping using contraceptive and then just seeing how things happen, that trying to get pregnant is might be some way questioning the role of God and nature in this process. So what can I do? Well, we can discuss age-related decline in fertility with all women 30 years of age or older. We can inform them of the possibility of egg freezing, and we can incorporate this into your regular counseling. And remember that your goal as a provider is not to provide contraception, but to provide family planning, which incorporates both potentially incorporates contraception, but also future reproductive health. So this is how you can help counsel your patients regarding the risk of age-related decline in fertility. This is data from Time to Conceive, where we followed women from their initial attempts to conceive until they conceive. This study focused on women 30 to 44 years of age. What you see on the x-axis is the age of the woman, and then on the y-axis, the cumulative probability of conceiving after 12 cycles of attempting. We have 2 different lines. The yellow line is somebody who has never conceived or nulla gravid, and the green line is somebody that has conceived previously. Now, the yellow line may apply to your patient, but the green line, I think, gives us a better understanding of what is the actual effect of age-related decline in fertility, because you know everything else is working well. So it's really focusing on the aging process itself. And what you see here is fertility stays relatively stable until age 35, and then we see a subtle decline in fertility until the fertility rates are about half that of where they were at age 40. They're about half that of what they were at age 30 or 31. So once again, relatively stable until around 34, 35, and then a subtle decline until age 40, which it's half that it was at age 30. I should note that between 40 and 43, there's a much more significant decline. So what age should a woman consider egg freezing? Well, this is another study. It was actual a study done by Dr. Messon and I and a number of other investigators, in which we were trying to do some modeling to best advise women as to when to freeze their eggs. On the x-axis, you see the age of the woman when she decides to freeze or not to freeze her eggs. So this is at the time she's making that decision. And then on the y-axis is her probability of live birth, should she decide to freeze her eggs or not freeze her eggs, assuming that she tries to conceive 5 years later. So what we found here is that if you looked at age 37, this is where you saw the maximum benefit in freezing your eggs. Here on the blue line is if you the cumulative or the probability of achieving a live birth if you chose to freeze your eggs at any age, and the red line is if you chose not to freeze your eggs at any given age. And what you see here is that the greatest difference between the lines is at age 37. So those women had choosing to freeze their eggs at 37 had the most benefits over the women not choosing not to freeze their eggs at 37. But if you look at the possibility of achieving an overall live birth, if you freeze your eggs at age 37, it's only 50%. However, if you want to say, when is the highest birth, when are you going to have the highest probability of achieving a live birth? Well, that would be if you look around age 26. However, there's very little difference in benefit of freezing your eggs between freezing your eggs and not freezing your eggs at age 26. And that is because we really don't see much of a benefit between freezing or not freezing your eggs until you get over the age of 30. Conversely, when you look at age 40, overall, there's a small benefit, meaning the lines start to get smaller in between the two lines out here. However, the overall live birth rate is more around 20% at over age 40. So what we kind of concluded was freezing somewhere between age 30 and 33 may be the best age, given that it was still a high overall live birth rate, and there is a difference, a significant difference between those women that chose to freeze and to not freeze their eggs. So a long-winded answer to the question as to how to help you might counsel your patients. But I think it's important to, first of all, discuss the process of ovarian aging or the age-related decline in fertility and the possibility of egg freezing and when that might occur. What else can I do, or what else can we do to help decrease the disparities in infertility between Black and white women? Well, we should be screening and referring all women with infertility to a reproductive endocrinologist and infertility specialist. For women less than 35 years of age, they should be referred after 12 months of attempting to conceive. And for women 35 years of age or older, after 6 months of attempting to conceive. However, you should refer women sooner who have risk factors for infertility. So if a woman has irregular menstrual cycles, meaning she's not having regular predictable menstrual cycles, she's probably not going to get pregnant in the next 12 months. So you might as well go ahead and refer her now. So refer sooner with risk factors such as irregular menstrual cycles, surgically proven endometriosis, or a history of pelvic inflammatory disease. Also, consider rewording the question when you're talking to your patients. Instead of saying, how long have you been trying to get pregnant? Consider variations on this. How long have you been having regular intercourse without doing anything to prevent pregnancy? They may not consider themselves to have been trying. However, they may have been having regular intercourse without doing anything to prevent pregnancy. So it's important to keep this in mind so that we don't not refer somebody because they weren't trying to conceive. What else can you do? Well, we can regularly screen and treat women under 30 years of age for gonorrhea and chlamydia. We can also correct misconceptions regarding tubal ligation and remind them that this is a permanent sterilization and is not a reversible form of contraception. It's also important to discuss fertility sparing treatments for fibroids, such as medical management and fertility sparing surgeries, such as myomectomy or hysteroscopic resection. Thank you. That's all I have today. It was a brief talk, but I hope you learned something, and I'm happy to answer any questions that you may have.
Thank you so much, Dr. Steiner, and welcome folks to chat in questions. Also, I think we are a relatively small group. Oh, accidentally moved us forward. It's very sensitive. So if anybody has a question they would also like to ask, please feel free to take yourself off mute and ask out loud or a discussion point. While folks are thinking of questions, do you just want to share, do you have an evaluation link for if anybody would like to provide feedback, and then also just sharing our social media, and that we have an event coming up next week on the 15th from 12 to 4. If you haven't already registered, please go to Before and Beyond to register. And writing our newsletters. And I'm gonna
I have one question, Catherine.
Yeah, go ahead. I was just gonna stop our share so everybody could see each other and chat.
So one thing that I know has come up as we've worked in, with folks in public health, or particularly serving folks in low resources, is kind of where to send people next when the cost of fertility treatment looks so prohibitive. And, kind of options that you've seen, or even understanding that there might be stages of treatment or things that are lower cost that folks can try first. So I didn't know if you would want to discuss that at all, just since a lot of our folks are care managers or public health folks, or seeing people in federally qualified health centers and places like that.
Great. Well, okay, so I am seeing a number of people on here whose names, there are some REIs, so hello to all of you. But I wanted to just mention that I think a big obstacle these days is the concept that if somebody is being sent to a reproductive endocrinologist, they're being sent for in vitro fertilization. And that is not the case. We do a lot of other things besides in vitro fertilization. And there are a lot of, I'm not going to say inexpensive, but there are less expensive techniques that can be employed to help women conceive. And really, IVF, it tends to be the last stage of treatment. Medications themselves, especially some of the oral medications you can buy at Target right now for $10 treatment. So there are definitely treatment options that are affordable. So I really hope that I don't want that to be an obstacle towards referral. Unfortunately, we do know that insurance tends to, Medicaid does not cover any evaluation or treatment of infertility, and most insurance plans, I've noticed, tend to cover evaluation, but not treatment. And of course, if somebody has no insurance, then the issue is the cost also of the evaluation, in addition to the treatment. But there are a number of, as I mentioned, especially things like irregular menstrual cycles, that can be addressed with medications very inexpensively. So I just think perhaps getting beyond our personal burden of thought process that every reproductive endocrinologist, every time I refer to a reproductive endocrinologist, they can't offer anything because all they have to offer is IVF. That really isn't the case.
Thanks, that was great. Folks in the chat mentioned Resolve as it's the national organization that is focused on fertility and infertility, and they do have specific support groups geared towards Black and Indigenous people of color. There was another question around kind of mechanisms or reasons for the disparities you brought forward, such as why Black women receive more tubal sterilizations or hysterectomies. And do you have thoughts about intervention on those more upstream factors? Is it education? Is it policy? Like, what needs to change there?
Well, that's a great idea. My assumption is it needs to be, I'm sure it's multifactorial. I think there's definitely evidence of increased burden, right? So there are more fibroids, they're larger, and they occur at younger ages. So I think it's important that there may just be some inherent component to that. And I know there's a lot of work underway to try to delineate what that underlying biology might be, although I get concerned when we talk about biology and when we're talking about race. But people talk about different genetic or enzyme differences, such as aromatase and activity in the fibroid itself, and then age of menopause, parity, and age of menarche. There are a number of things that have been proposed that may be the underlying reason why fibroids are more prevalent amongst Black women. And then you get into how to manage the fibroids, and some of that may be, once again, how it's being managed may be differences to underlying tumor burden. But I think we have to always question and make sure that people are getting the appropriate training to know about and are offering the same treatment modalities, or is basing it on medical need, and not based on just some assumption regarding that patient in front of them. I think it's difficult if you get into policy. Not a big fan of policies regarding reproductive organs these days, but perhaps education at a clinician level, and then also in the community regarding these options and fertility sparing options.
Thanks, that was great. Trying to see if there are any other questions in the chat. In terms of providers and public health folks, do you have thoughts about how they can advocate for either increased access to fertility services or better coverage for, fertility care?
Yeah, well, I didn't even begin to go into that. And that would have been another section which I could have brought up, but I think it is, once again, what audience are you talking to? And as a provider, I think most providers are incredibly frustrated that there is not universal coverage for fertility services. There are a couple mandated states where if you have insurance, it mandates that fertility services are covered, but that is unique by state. I am incredibly impressed. I think one of the, actually, in some ways, although we've said this doesn't ameliorate all of the inequities, access to having insurance coverage seems to do help. I've, on a more personal note, as a physician, I've had patients for many years who desired to do in vitro or needed in vitro and were unable to afford it, and then became a driver at Amazon or played some role in Amazon, and Amazon has complete coverage for all of their employees, which I think is amazing, because they have employees of all kind of SES level. I mean, obviously they're all employed, but as opposed to in the past, really, to get infertility coverage, you had to work for Google or some sort of white collar organization. So I think the more we can get businesses, maybe that might be the route to go, is encouraging more businesses to provide coverage for fertility services, because that's really, or include that in their insurance plan, because these days, that's really who defines whether or not somebody has access to infertility coverage, is whether or not their insurance plan does cover it. And that's going to be at the company level.
Yeah.
That's not the easiest level to advocate. And then on a state level, we can certainly work there. But,
could I add something? That was a wonderful answer, Dr. Steiner. Can everyone hear me? This is Betsy Campbell. I work for Resolve, the National Infertility Association. And we try to address those exact issues that you mentioned. We do know that most people get their insurance through their employer. So even if they're in a state with a mandate, self-insured employers don't have to abide by state law. And so we have a program specifically geared to people to advocate at their companies, to go to HR and to make the ask. So I'll put that resource in the chat. It's basically, you can email us at coverageatwork@resolve.org. And we've helped, over 500,000 people get access through their companies by using our resources. And literally, it often takes just one person making the ask, and HR doesn't even realize that there is a gap in their benefits till it's brought to their attention. And then also, we do work in states to try to pass these state laws. So in the past 3 years alone, 5 states have passed new infertility insurance laws or improve their existing laws. So again, we would love to work with people, because it's not only frustrating for patients, but also providers not to be able to provide the standard of care that their patients deserve. So we definitely know that cost is the major obstacle to care, and we want to remove that as an obstacle. So we love to work with patients and providers to fill this, the gaps in access to care for everybody. So thank you.
Oh, thanks for sharing that, Betsy. That was really a good resource to know about. I do think too, just as the conversation, and I'm wondering, Anne, if you've seen this in kind of the reproductive medicine world, but within women's health and maternal health, there's been a lot of focus on disparities in outcomes for Black and Indigenous women. And there's certainly, there's been a Surgeon General's report about, disparities in maternal outcomes and things like that. Do you feel like the connection has been made to kind of these preconception issues and the fertility and how that affects, both from a reproductive justice perspective, but also from a, outcomes in general? Do you see that conversation happening?
I don't see it going back that far. I mean, I would assume nobody here, this is a group focusing on preconception. Unfortunately, I don't think we see it happening. And I think the natural inclination is to blame, well, people should be getting their preconception visit, but I think it needs to come back even further to having those discussions with patients about their reproductive health, and really switching our focus, as you said, to reproductive, this reproductive justice concept that we're not just here to provide contraception, but we're also here to help people have good reproductive health. And that means being aware of potential barriers to reproduction and helping decrease those barriers. We know if women delay attempts to conceive later in life, there are higher risk of pregnancies inherent to that. And we know if there are fibroids likely present, certain types of fibroids, there may be more complications in pregnancy. So I think just switching that overall narrative or away from just contraception to family planning, I think we can really do a lot of good and potentially impact those overall outcomes and those disparities and those outcomes that people seem very interested in at this time. But that's a great connection, Erin, which I haven't made before, but I think we should.
Thank you. I'm looking to see if there's any other questions. We are so lucky to have had your presentation today. This presentation will be archived if folks want to refer to it. And we'll open it, I guess, any final questions before we? Catherine, do you want to take it to?
I think that's it. Thank you again, Dr. Steiner, and I'll put the link back